Good morning, everybody. I'm Dr. Samanna Nakkar, a senior lecturer in anesthesiology attached to the Department of Oral and Maxillofacial Surgery of Faculty of Dental Sciences, University of Peradeniya, and I'm a consultant anesthetist attached to the Teaching Hospital Peradeniya and Dental Hospital Peradeniya. So, in this lecture, we are going to discuss about preoperative assessment and preoperative care. So before moving to preoperative care, I want to introduce another term, perioperative care. So what do we mean by perioperative care? Peri means around, before, during and after of an event is what we roughly mean by the word peri. So when it comes to perioperative care, what we mean is preoperative care, which is the care you provide to a patient before starting a surgery. Intraoperative care is what you offer as care during a surgery, and postoperative care is what you mean by care you provide to a patient after surgery in the postoperative setting. Right, so we will move on to preoperative care now. So preoperative care is a very important stage of care during a patient's perioperative setting because an operation, a surgery and an anesthesia always puts a patient's life at a higher risk. Therefore, this is the time you have as a doctor to assess patient's medical conditions and to optimize those things and prepare the patient for surgery. Right, so there are a few subtopics that we need to discuss under this heading preoperative care. Preoperative assessment is in fact the main focus in this lecture, and under that we have focused history, examination and investigations. Then we need to talk about preoperative optimization or preparation of the patient for surgery and anesthesia, continuing medications, providing pain relief or analgesia, fasting, preoperative fluids, electrolyte and acid-base management, and obtaining informed consent for both surgery and anesthesia. Right, so the most important thing that we need to focus on under this topic of preoperative care is preoperative assessment. So as you all know, any medical examination, any medical assessment comprises of history taking, examination and investigations. So same thing applies for pre-operative assessment where you need to take a history, do an examination and do some investigations to complete your assessment. Now here I have mentioned a special term called focused history, relevant examination and relevant investigation. So now what do we mean by a focused history? Well, the patient has presented with a particular problem and it's generally to get a surgery done. Or let's say the patient has admitted with a trauma and you have identified a traumatized tissue and you need to fix that. Let's say reducing a fracture. And so in a situation like that, we need to concentrate on the problem mainly and things around that. So that's what we mean by a focused history. And a relevant examination is also an examination relevant to what you found in the history and with the patient's presenting complaint. And similarly, relevant investigations are also investigations that you perform relevant to the history and examination you have done. So this is very important and useful for both surgery and anesthesia because both surgery and anesthesia are associated with higher risks to patients' lives. Right, now let's see what we mean by a focused history. So the patient has presented with a problem to the ward and you are the doctor in the ward. Let's say the problem is an oral cancer, or the patient has presented as a trauma victim with a maxillofacial trauma, or let's say a mother has brought a child with a cleft lip or a cleft palate for correction. So this patient is presented with a specific problem. So what we mean by a focused history is we are largely concentrating on the presenting problem. I'm not saying that we are ignoring everything around that, but if we try to concentrate on lots of minor medical issues that we encounter in the history taking and examination, well then doing the surgery may get delayed, and correcting those things sometimes may not be possible, and correcting those minor irrelevant problems may not be relevant for the current problem that the patient has presented to you. So in this preoperative care, we are largely focusing on the presenting problem, and we are also trying to correct medical issues that are around the medical around these surgical problems, which have implications on surgery and anesthesia. Right, then we need to see whether the patient has comorbidities. So what do you mean by comorbidities? Morbidities are diseases, illnesses. So we need to see what comorbidities has the patient got. So we can straight away ask the patient, well, do you have any other medical problems? So we can ask the mother whether your child has other medical problems. And if so, when has the patient got these things? Whether they are present from birth, or has the patient got through halfway in his life, let's say something like high blood pressure and diabetes, and how severe is the illness, and have there been any acute exacerbations which needed hospitalization, and what is the recent control of those conditions, and what kind of treatment is the patient undergoing for those comorbidities. For an example, take a patient with high blood pressure, hypertension, or diabetes, or bronchial asthma in an adult, for an example, or even a child can have bronchial asthma. So we can ask for how long has the patient has been having high blood pressure or diabetes or bronchial asthma, how severe is the illness, whether the patient is getting asthma only occasionally, or only when the patient has upper respiratory tract infections, or the patient might say I'm having asthma every day, therefore I'm on an inhaler. And hypertension and diabetes are things that are present every day. I mean, these are not illnesses that the patient would get episodically. Once the patient gets high blood pressure and diabetes, generally they will be there for the rest of their lives. And how severe are the illnesses? For example, how nicely or poorly is the blood pressure or diabetes conditions are controlled? What are the blood pressures? What are the sugars? Then acute exacerbations. So, for instance, a diabetic, whether the diabetic patient has had high blood sugar levels or very low blood sugar levels in the recent past. So I have mentioned in the next thing also, recent control of the illness is very important. And for an example, if the patient has had a very poor control of high blood pressure and diabetes in the recent past, last few days, last few weeks, that has a direct implication on surgery and anesthesia. And things like congenital heart diseases. So what kind of treatment is the patient on? Is the patient on regular treatment? For instance, taking daily treatment like inhaler for bronchial asthma, or oral hypoglycemic agents, so insulin for diabetes, or antihypertensives for hypertension, things like that. And if so, what kind of medications, how frequently, what are the doses, are there side effects related to these medications? It's very important that you ask these things and document these things in your medical records. Then if by chance the patient does not mention anything about his comorbidities, and still it is good to ask the patient about important medical conditions under a direct inquiry. For instance, even if the patient says, no, I have no other medical problems, it is still important for you to ask, if it is an adult patient, whether you have got high blood pressure, diabetes, bronchial asthma, heart diseases like ischemic heart disease or cardiac failure, chronic obstructive pulmonary disease, strokes, since those are serious illnesses which can have a serious impact on your surgery and anesthesia. It is always important to ask the patient about the presence of these illnesses and document it in your medical records as to whether these are present or absent. So it is very important to document that these illnesses are absent also, if they are absent. So going into depths of history, now you can ask whether the patient has any allergies to medicines. If so, what are the medicines and what were the allergic reactions the patient had? So sometimes patients refer to side effects, so adverse effects of medicine as allergies. So don't just document it saying the patient is allergic to, let's say, ibuprofen or paracetamol. So allergy to paracetamol is a rather rare thing. So ask the patient, okay, so what is the reaction you had? So sometimes the patient may have taken several other medications, and the patient is referring it as an allergic reaction only to paracetamol. So then, if so, what reaction? So let's say if that was whether that was a skin rash or wheezing or angioedema, or whether the patient went into an anaphylactic shock and the patient collapsed, was he hospitalized? If so, is there a diagnosis card or alert brace that has been issued from the hospital? Look at those things, and after analyzing those carefully, only you should record in your records that the patient is allergic to medicine. So if you record it, it's a very serious thing, and thereafter all other doctors and nurses who are reading these documents do not have to go to great details because you have done it once, and all what they need to do is to avoid that medicine and remind the patient also to not to use that medicine before, and to remind doctors and nurses whenever they are going to take medications from a doctor. Then you also need to ask the patient whether the patient has undergone any surgeries or anesthetics before. Sometimes the patients have undergone surgeries under general anesthesia or regional anesthesia or local anesthesia. Even if the patient has undergone a surgery under local anesthesia, still it is important to ask those things and record what exactly those surgeries are. And it is especially important to see whether the patient has had any complications due to those surgeries. So sometimes the patient may be coming for the same surgery and you need to avoid those complications. And there can be implications of those complications on this time surgery and this time's anesthesia. So it's very important to go into details about those things, explore the patient's diagnosis cards and medical records issued by the previous doctors and previous institutes, and record those things in your medical records this time. And also check with the patient whether the patient has any infections currently, especially upper respiratory tract infections, which are very common. So the commonest upper respiratory tract infection is common cold, which patients sometimes refer to as a cold, sometimes referred to as a misnomer, like saying flu. So flu should be we should be reserving the term flu for a influenza, not a common cold. So sometimes patients refer to it as flu. So common cold, acute bronchitis. An acute bronchitis patient generally has a cough and a slight difficulty in breathing, or maybe a wheeze, whereas common cold patients generally can have mild fever, largely nasal symptoms, and there can occasionally be a sore throat. So it could be a pharyngitis or laryngitis, and pneumonia. So sometimes patients with mild pneumonia can stay at home and can present to you for a different surgery. And with the current COVID concerns, we always need to check with the patient whether there's a possibility of this patient catching COVID-19. So we can ask the patient whether he had any exposure to COVID patients, whether he traveled abroad or whether he went into area with restrictions or lockdown areas, whether he had any close contacts with patients who had COVID and things like that. Then another important thing is to check whether the patient has gastritis, because gastritis is very common these days, and to see whether the patient has reflux or gastroesophageal reflux disease or gastroesophageal regurgitation. So the abbreviation is GORD. Because once a patient is admitted to a hospital, and sometimes the patients may have a flaring up of gastritis due to stress, and reflux may get flared up, and the patient may present with chest pain in the middle of the night to early morning, And it's very important to start the patient on prophylactic treatment for gastritis and gastroesophageal reflux to prevent any episodes like that. In addition to that, there's another importance of preventing reflux, because when you are anesthetizing a patient, when you are giving general anesthesia for a patient, patient loses the consciousness and the ability to protect the airway. So all of us know, when we are awake, when we are not anesthetized, if reflux stuff comes from the stomach to our throat, we can either swallow it or we can spit it out. But once the patient is anesthetized, the patient is not conscious and patient has no airway control or airway reflex. Therefore, the reflux stuff that is coming up from the stomach up the esophagus to the throat can easily go down the trachea and can cause pulmonary aspiration. So it is very important to prevent that. Otherwise, the patient can end up having an airway obstruction due to reflux, which can cause even sudden death, and or can cause hypoxia and serious cerebral ischemia, and could cause an aspiration pneumonia. Then it is also important to see whether the patient has any loose teeth and whether the patient is wearing any special dental appliances like dentures, because again, when the patient is unconscious during anesthesia and in the postoperative period, when the patient is drowsy and less conscious, if there are loose teeth, they can get dislodged and can cause airway obstruction or pneumonia. Similarly, dentures and special dental appliances could also get dislodged and cause sudden airway obstruction. Then it is very important to check routine medications of the patient. Ask the patient, let's say the patient has said, no, I'm not having any medical illnesses, but still it is important to check with the patient whether the patient is on any routine medications. Sometimes now a patient who has already told you, no, I have no medical illnesses, might say, well, I'm taking a particular tablet in the night or two tablets in the night, and you take the medical records and see, then to see these are either oral hypoglycemic agents or anti-anginals or antihypertensives or bronchodilators. So now you come to know that patient has these medical illnesses. So it's very important to ask the drug history and medication history, and if so, which drugs, so which medications are being used, what are the doses, what is the frequency, when were those taken last, and it is also important to see whether there are side effects and adverse effects related to those medications. Right. Now let's say we have finished the focused history and now we are moving on to relevant examination. Now here again I have used the word relevant because we are doing an examination relevant to what we found out from the history and an examination relevant to the presenting problem. Right. Okay. So the first thing is to do an examination related to the presenting problem, which has an importance both for surgery and anesthesia. Example, let's say mouth opening. Now, in your ward, when you are working as a doctor in a dental ward or a maxillofacial unit, patients who present, most of the times they will have a complaint related to the mouth, and well, it could be due to related to a jaw, teeth, tongue, throat, neck, forehead, or the face. And so see what exactly is the problem, what is the extent of the problem, can the patient open the mouth, whether there's bleeding, oozing, whether there's infection, sepsis, whether there's a septic root, whether there's drooling of saliva, and whether there's a possibility of an abscess, fracture. So all these are important both for surgery and anesthesia. Then do a general examination. So see whether the patient is pale. So it's very important to see this because there are lots of patients who present to, especially to government hospitals with pallor. So largely due to malnutrition. So this has a direct impact on hemoglobin levels and serum protein levels. And hemoglobin levels have a direct impact on anesthesia because all of us know to deliver oxygen to tissues, you need hemoglobin. So once a patient is anesthetized, the patient is going into a critical, illness, and delivering oxygen to myocardium, brain, and all other organs are very important. And if the patient hasn't got an optimal hemoglobin level, well, the patient can't deliver optimally oxygen to peripheral tissues. So it's very important to see whether the patient is pale. Look at the body habitus, whether the patient is overweight, obese, or emaciated. So both have different implications on surgery and anesthesia. An emaciated patient, for an example, have poor reserves. So whether the patient can undergo a major surgery like that, whether you need to give some nutrition and postpone surgery and call him in a few weeks time or maybe after a couple of months time. Well, if that is an urgent surgery, emergency surgery, you have to ignore those things and go ahead, but you have to liaise that with the anesthetist because it has implications on anesthesia as well. Then overweight patients and obese patients have another set of problems. So they generally have associated comorbidities like high blood pressure, dyslipidemia, or hypercholesterolemia, ischemic heart disease, maybe cardiac failure. They may be obese and having obstructive sleep apnea. Secondary to that, they may be having pulmonary hypertension, and all those things have serious implications on surgery and anesthesia. See whether the patient is icteric, jaundice, which is suggestive of a liver problem. See whether the patient has ankle edema, which could be due to multiple reasons. It could be due to liver illnesses where there's poor production of serum proteins, or renal impairment, or could be due to heart failure. Right, so after the general examination, move on to a system examination. So basically you have to cover the cardiovascular system, respiratory system, liver and the kidneys largely. Under cardiovascular system, well, you follow the basic examination pattern you learn under medicine. So just to remind, so you need to check the pulse, blood pressure, and do a precordial examination. Under precordial examination, you need to do an inspection, palpation, percussion, and auscultation. See what the heart sounds are, whether there are murmurs suggestive of valvular heart diseases, and things like that. Right, now you need to move to the respiratory system. So where you have to check the respiratory rate, pattern, see whether there's an audible wheeze or whether the patient is coughing, and do a lungs examination. So again, under lung examination also you do an inspection, palpation, percussion, and auscultations. Especially see whether there's vesicular breathing, which is the normal breathing pattern we expect, where we have a longer inspiration and a shorter expiration. And if there's bronchial breathing, which generally is suggestive of a lower respiratory tract infection, especially a pneumonia. See whether there are rhonchi or crepitations. So rhonchi refer to bronchospasms, which generally are due to bronchial asthma or chronic obstructive pulmonary disease when those conditions are poorly controlled, or it could be due to bronchospasms related to associated with a lung infection also. See whether there are crepitations. So crepitations could be due to a lung infection like pneumonia, or could be due to heart failure, or could be due to conditions like lung fibrosis. Then do a basic examination of the liver and the kidney, and generally if the patient has a liver problem or kidney problem, patient would have been detected by other medical doctors earlier, and generally they will have diagnosis cards and they have illnesses recorded, but well, sometimes those things may have been missed, so it is still very important for you to look at those systems systematically as a doctor. So a liver patient, see whether the patient is icteric, as I mentioned under general examination, and do a basic examination and see whether the patient has hepatomegaly, splenomegaly, ascites, and things like that. And a kidney patient under renal system, just see whether the patient has ankle edema, puffiness, especially whether the patient's face is puffed and whether there's general body swelling, and whether the patient has a urine output, and do a basic examination of the abdomen to see whether there are lumps in the abdomen which are suggestive of an enlarged kidney, which could be due to a hydronephrosis or polycystic kidney disease. Right, now we will move to relevant investigations. Now, investigations are done here when you are preparing a patient for surgery and anesthesia to substantiate your findings in the history and examination. So you should not be doing unnecessary, irrelevant investigations, because one thing is all investigations are expensive. Even if you do it in the government setup, still it is a cost to the government, to the society, and finally to all citizens of the country. And sometimes it's a waste of time and labor if you do unnecessary investigations. You have to draw blood or collect other specimens like say sputum or urine, send all those things, unnecessary specimens that have been collected, to the laboratory, trace investigations, and sometimes if you get a bizarre result, then you do not know what to do because it is not relevant for your history and examination anyway. So do only the relevant investigations. So for instance, a full blood count is generally important for all major and intermediate surgeries. And a random blood sugar generally is important for patients above roughly the age of 40 years, because there's a higher chance for a patient to get diabetes mellitus or poor glycemic control after the age of, let's say, 35 or 40 years. So it's not an important investigation in a young person. So if you get a 25-year-old, there's absolutely no need to check a fasting blood sugar or random blood sugar. If you have a child, you do not have to do a fasting blood sugar or random blood sugar. And also if the patient has diabetes, it's important that you check sugars generally 3 times a day in their perioperative stage. And also if a patient has high blood pressure, ischemic heart disease, dyslipidemia, elevated serum cholesterol levels, generally there's a tendency for them to have diabetes also. Therefore, it's important to check for blood sugar levels in them also. So like that, there's a relevance of doing blood sugar levels in those patients. Then ECG, electrocardiogram. So it's an investigation to see largely whether there's cardiac disease. So we generally do it on patients above the age of 50 years, because that is the time you generally start getting heart diseases like ischemic heart disease, cardiac failure, degenerative valvular diseases, and things like that. So it's important to do a cardiovascular examination and an ECG in patients with a history of or examination findings suggestive of a cardiovascular system disease or respiratory system disease. Now, why respiratory system? Because respiratory system is physically so closely associated with the cardiovascular system. Lungs and heart are together, working together, and physically also they are close by. Therefore, it's important to do an ECG even on patients who have a serious respiratory disease like long-standing bronchial asthma or COPD. And obviously in patients with cardiovascular diseases like patients with high blood pressure, hypertension, or heart diseases. Then a chest x-ray. So a chest x-ray again, uh, things that we are interested in seeing in a chest x-ray would appear in patients with an age above 60 years. So there's no point in doing a chest x-ray in a 25-year-old if they are coming for a simple tooth extraction, because we do not expect their chest x-ray to be abnormal if there's nothing suggestive of a cardiovascular respiratory disease in the history. So perform a chest X-ray in patients above 60 years and in patients who have cardiovascular respiratory system disorders like again hypertension, heart disease, bronchial asthma, chronic obstructive pulmonary disease, heart failure, respiratory failure, or anything like that. Then liver function tests should be performed only in patients in whom there's a suggestive history and examination of liver diseases. Well, you can do it on alcoholics or patients who consume a lot of alcohol also, because their liver is expected to be affected. So under liver function tests, you can do serum bilirubin levels, SGOPT, SGOT and PT levels, prothrombin time, alkaline phosphatase, gamma GT levels, and INR, and finally serum total proteins and albumin levels. Then under renal or kidney function tests, again you have to perform those things if there's a relevance. So commonly if there's a history of renal disease like hydronephrosis, hydroureter, polycystic kidney disease, or if there's a history of high blood pressure and diabetes mellitus, then we know there's a chance of those patients having impaired renal functions. Yes, then do renal function tests like serum creatinine, blood urea, serum electrolyte levels, and urine microscopy to see whether there are proteins appearing in urine. Right, earlier I said in the history we need to see what kind of medications is the patient on. So generally, even in the perioperative setting, we have to continue all medications that the patient has been on, except for a few medicines. A few medicines you will stop altogether, and a few medicines you might modify the way the patient has to take those things. Generally, patients who are on antiplatelet agents like aspirin, clopidogrel, we prefer to stop those things before surgery because patients who are on antiplatelets have a higher chance of bleeding during the surgery and in the postoperative setting. However, when you stop antiplatelets, again you have to think twice whether why the patient is on antiplatelets for a purpose. So this may be to prevent another fatal myocardial infarction. So by stopping the antiplatelet to minimize bleeding during surgery, you are exposing the patient for another risk, and that risk could be fatal if he gets a fatal myocardial infarction. So maybe you have to liaise with a consultant physician or medical staff, emergency medical registrar or senior registrar, or sometimes with the cardiologist to see whether it is suitable, whether it is safe to stop antiplatelets. Sometimes the patient is on 3 antiplatelet agents. You might stop 2 and leave the patient only on aspirin. Sometimes the patient is on 2 antiplatelets like aspirin and clopidogrel and you stop 1. Let's say you stop clopidogrel and you let the patient be on aspirin. Now, why do we want to stop antiplatelets? As I mentioned earlier, there's a chance for patients to bleed more during the surgery due to the antiplatelet effect. And especially it's an issue when you are scooping bones, when your surgery deals with bone, because it's very difficult to stop bleeding oozing from bones with pressure or by diathermization, and you can't apply a tourniquet, and it's very difficult to elevate those tissues. So we don't want to have unstoppable torrential bleeding also. And during the surgery, if by chance patient bleeds, if there's serious bleeding you detect during surgery, and you can transfuse this patient platelets, and thereby you can counter the effects of antiplatelet agents. Then patients who are on anticoagulants like warfarin and heparin, again these have serious implications on surgery because as the surgeon is cutting and excising tissues, there's a chance for patients to bleed. So stopping warfarin and heparin again has to be with modifications, with precautions, because the patient is on warfarin and heparin for a particular purpose. So for instance, this patient who is on warfarin may be on warfarin because he has an atrial fibrillation, and or maybe because the patient had a serious deep vein thrombosis in the recent past, maybe 1 month back. Thereby, by stopping warfarin, you are exposing the patient to a cardiac thrombus in case of a atrial fibrillation patient, or generating a new deep vein thrombosis, or extending the patient's already having a deep vein thrombus. So when you stop warfarin, so warfarin is a drug which has a longer duration of action. So when a patient is on a drug which has a longer duration of action, controlling the effects of it is very difficult in the intraoperative setting. So you stop warfarin and change to something like heparin, which is a relatively shorter duration, shorter duration of action, so 8 to 12 hours. So you have to liaise with the physicians or hematologist and then do it. So you have to do a series of uh, prothrombin time, INR, and APTT tests. Maybe you have to do some bleeding time and clotting time tests and advanced coagulation studies with the consultation of the hematologist or the physician, and then start the patient on something like heparin, which can be given on even the previous night before surgery, and avoid giving the dose of heparin on the day of surgery and do the surgery. And after surgery, start the patient again on heparin. So heparin has a very quick onset of action, and then you can start the patient quietly on warfarin also. Once the effect of warfarin has taken place, you can stop heparin. Then also we know we keep patients fasting for surgeries. We will be discussing that in another slide that is to come. And during that fasting period, we have to stop the patient's oral hypoglycemic agents and insulin because the patient is not taking calories. So when you give drugs that can lead to hypoglycemia like insulin and oral hypoglycemic agents, the patient can go into serious and fatal hypoglycemia. Therefore, do not give oral hypoglycemic agents like say metformin or glibenclamide and insulin, all kinds of insulin. Stop those things. Check patient's sugars before surgery, let's say 1 to 2 hours before surgery. Right now, so you need to continue all medications except for the few medications that I mentioned in the previous slide. So, for an example, patients who are on antihypertensives, anti-anginals, antiarrhythmics, bronchodilators. So, the bronchodilator could be an oral or inhaled one. Steroids, drugs used for gastritis or gastroesophageal reflux like omeprazole or ranitidine, anti-epileptics, lipid-lowering drugs. These drugs should be continued, including the drug dose on the same day of surgery. Maybe you can give it about 2 hours before surgery, even if the patient is fasting, it's quite okay. Well, there are a few exceptions. Say antihypertensives, you can check the blood pressure, and if the blood pressure is above 160 by 90 millimeter mercury, then it's always advisable to give an antihypertensive dose. If the patient is on sometimes 2, 3, or 4 antihypertensives, maybe you can give 1 or 2 at least to control the blood pressure. Otherwise, the blood pressure will be very high after starting the surgery. Right, so what have we discussed so far? We did a preoperative assessment with a history taking, examination, and investigations. And when we looked at the patient's medications and decided which drugs to be continued and which drugs to be discontinued. And now we need to do a preoperative optimization or preparing the patient for surgery and anesthesia. So our preparation will depend, or our optimization will depend on the findings of our preoperative assessment. What did we find in our history, examination, and investigations? What background medical problems, what comorbidities has the patient got, and what type of surgery, where in which part of the body is this surgery going to happen, and what type of anesthetics are we going to use, whether this is a general anesthesia, a regional anesthesia, or local anesthesia. And so rest is going to depend on these things. So further into preoperative optimization, so see whether we need to do further assessments based on what you have found in the history, examination, or investigations. And so as I mentioned earlier, continue or discontinue routine medications, the patients that has been on all this time. Then you might have to liaise or contact or communicate with other specialists or other disciplines. Example, with general medical staff, general physicians, general surgeons, cardiologists, microbiologists, nephrologists, anesthetists, especially if the patient is coming for a surgery, you have to discuss special problems with anesthetists. Intensive care unit staff, if the patient is going to need an intensive care bed after surgery. Operating theatre staff, if the patient needs special things for this particular surgery. Talk to the blood bank staff if the patient needs blood reserved for surgery or special blood products like platelets, fresh frozen plasma, and cryoprecipitate and things like that. And see whether the patient needs new medications based on your history examination and investigations or as prescribed by other specialists. Let's say the patient has been seen by the cardiologist or general physician and he has suggested to staff a few new medications. If so, start those patients on those medications. And so it's better to arrange a time for a discussion with the patient and the patient's next of kin, especially if the surgery is going to be a major surgery or if it is an intermediate surgery with special implications. Better to arrange a time and get going with your rest of the preparatory work, optimization work, and then start the discussion with the patient when the time arrives. Okay, let's say you have completed basic preparation of the patient for surgery and anesthesia. Now you need to remember a very important thing, that is fasting for surgery. So keeping patients fasting is a very, very important thing when it comes to preparing the patient for surgery. Why? Because the patients are at a higher risk of pulmonary aspiration when they are unconscious. So even if you are planning for a surgery to be done under regional anesthesia or local anesthesia, except for occasions where you are doing procedures on the dental surgery, minor procedures, in all other situations, it would always be better to keep the patient fasting, because if by chance your local anesthesia or regional anesthesia doesn't work, you might have to request an anesthetist to put the patient under general anesthesia. Then if the patient is not fasting, it's not very advisable to go ahead with general anesthesia. Now, what is our concern of patient not fasting? So if a patient is not fasting, there's always a risk of regurgitation or reflux of gastric contents up the esophagus to the throat. So once those gastric contents reach the throat, they will find an easier way to go down, which is the trachea, and cause pulmonary aspiration. So anything other than air spilling into the trachea can cause serious health hazard. It can cause airway obstruction and hypoxia and even sudden death if that is a large food particle. And or hypoxia can even cause permanent hypoxic brain damage. Even if the patient doesn't die now on the table, can die later. Or the patient might not die but may remain a vegetable due to permanent hypoxic brain damage. And the reflux contents, once aspirated into the pulmonary tract, can cause aspiration pneumonia or aspiration pneumonitis. Pneumonitis, we are referring to a chemical reaction more than an infection. So what are the steps that we are going to take? So we have to keep the patient fasting. When it comes to solids like say rice and curry, bread, roti, string hoppers and things like that, or short eats like rolls, patties, cutlets, etc., and fruits, vegetables, we have to keep them fasting at least for 6 hours. But it is always advisable to make that last meal, which the patient is going to take about 6 hours before surgery, 6 hours before anesthesia, try to make it a light meal. So something like sandwiches and a tea is advisable. Now, fruits, vegetables, green leaves, fried rice and fried noodles and things with a lot of oily stuff like rolls, patties, cutlets and things like that, they have poor gastric emptying. Therefore, that type of food tends to remain in the stomach for a longer duration of time. So the patient may be fasting for 6 hours or more, but still gastric emptying has not been completed because of the nature of food. So there's still a higher chance for these gastric contents of oily foods and heavy foods like fruits, vegetables, and green leaves to come up the esophagus due to reflux. And same thing applies to semi-solids also. Semi-solids after going into the stomach can behave like a solid due to the changes that are happening in the stomach. So better to keep even the semi-solid diet as a light meal if it is taken only 6 hours before. And so what about formula milk? So formula milk, uh, although it is a liquid at the time of drinking, and after going into the stomach, it tends to, behave like a solid or semi-solid. So better to keep 6 hours fasting for formula milk. And breast milk, it's okay for a infant or neonate to be fed 3 to 4 hours before surgery, before anesthesia with breast milk. But again, better get it done under supervision of nurses, nursing officers in the ward. And when you give that instruction to the mothers, you have to uh, understand that there's a risk of, well, the mother may continue to breastfeed the child up to the point of surgery or up to the point of anesthesia without your knowledge, and finally the neonate or the infant might end up having pulmonary aspiration followed by death. So nobody wants that kind of complications. And so big answer for that would be yes, ask the mother to breastfeed, and up to a point, maybe up to 3 to 4 hours before surgery and anesthesia. And you can give patients clear fluids even up to 2 hours before surgery, but I would say better to keep that also 3 to 4 hours before. Uh, and well, again, the amount of fluid that the patient is going to sip also matters. So better to advise the patient strongly to take only a few sips or a few teaspoons of the clear fluid. So the clear fluid could be water or glucose dissolved in water or glucose solution, plain tea, a clear fruit drink, something like apple juice, again under heavy supervision of nurses. A patient or the a child's mother can't give fluids up to 2 hours before surgery without being supervised by nurses. It's very dangerous. Right, so this is a diagram of performing direct laryngoscopy, procedure that we do during anesthesia to pass an endotracheal tube. So once the patient is anesthetized, we need to maintain the patient's airway and protect the airway. So this is an endotracheal tube. This is passed through the mouth or through the nose to the trachea, and this cuff which is here can be inflated to protect the airway. So this endotracheal tube serves several purposes. It is there to have the patency of the airway and also to protect the airway and as a means for ventilation. So through this tube you can give oxygen this way, you can give anesthetic gases this way, and carbon dioxide will come out again through the endotracheal tube. So this laryngoscope is there to facilitate intubation. So now when you look at the other picture which is on to your right, you will see the trachea and the esophagus. So trachea is more anterior on a patient who is lying, or it is more superior on a patient who is lying. Esophagus is just behind the trachea. So gastric contents can come up from the stomach up the esophagus to the throat like that and can spill into the trachea. So if you are anesthetizing a patient, if you are preparing a patient for an emergency surgery, a patient, let's say, has had a meal or milk, and but now the patient has to undergo surgery immediately. Let's say the patient is bleeding, so you have to stop bleeding in a surgery, so you have to anesthetize the patient. So something we can do is applying some cricoid pressure here while the patient is being anesthetized till the endotracheal tube is passed down the trachea like that, and protect the airway. Till that time you can press the cricoid cartilage and impinge the esophagus like that, press the esophagus, trying to prevent gastric contents coming up the esophagus. Right, so this is a chest X-ray of a patient who has sustained pulmonary aspiration now. So in this X-ray, I think you can basically see the trachea. So this dark line is the trachea, and the right main bronchus would come this way, left main bronchus would come this way, and gastric contents have spilled and come down the trachea and gone down the right main bronchus and cause some shadows here. And similarly, you can see some shadows here also, which is suggestive of pulmonary aspiration. Another very, very important step in pre-operative preparation and optimization is obtaining informed consent from the patient. Now, what we mean by informed consent is informing the patient, giving information to the patient about the surgery and about anesthesia, and then obtaining consent. Not just asking the patient to sign here in the medical records saying that I hereby consent for surgery and consent for anesthesia. So that is wrong. If you haven't given information about the patient and if you are not obtaining informed consent, that has no legal value, and for that matter, it has no medical value either. So discuss this with the patient directly, and if the patient is not in a capacity to understand, if the patient is a child or mentally subnormal, discuss it with the patient's parents or guardians. So explain the procedure. That is the first thing that you should do to the patient. Explain the procedure of surgery and procedure of anesthesia. Then discuss the benefits and drawbacks of the procedure with the patient. So what are the expected benefits and what are the possible drawbacks, weaknesses. So all medical procedures have drawbacks. So what are the possible complications of this surgery? So all medical procedures have a set of inherent complications. Not that every complication is going to happen to this particular patient, but we are talking about the possibilities of certain complications arising during this surgery or after this surgery on this particular patient, and allay anxiety and fear. So we should not create an unnecessary fear psychosis in the patient by just bombarding the patient with all kinds of unnecessary information also. So it's not fair by the patient because the patient is not a doctor. Patient is not a health staff person. Even if the patient is a healthcare personnel, still you should give only the necessary information and in a suitable manner to suit his background, his level of education, and his concerns. So, allay anxiety and fear. Answer questions if the patient has questions. And sometimes you might see the patient has a set of questions in his mind and he's trying to ask that. So, you are talking to the patient, he is not listening. So, best thing would be to stop your discussion and ask the patient, well, what are you trying to say? Tell me your question, and then you answer that question first. And also talk about alternative methods of treatment that are available. Let's say the patient does not like surgery, so then see whether you have any other thing, any other conservative way of managing this medical problem, let's say by antibiotics and cleaning and elevating the wound or something like that, having a drain. Or if it is a cancer, whether the patient could get away by doing radiotherapy and chemotherapy, and what are the possible advantages and disadvantages of those things also. And finally, this informed consent should be obtained in the written form. So verbal consent again has no value, especially no legal value. And get the patient to fill the consent form. There's a part for you also to fill, saying the name of the doctor who discussed, name of the specialist who is responsible for this patient's management, name of the patient, date, and things like that. And as I mentioned earlier, if the patient is not in a mental capacity to understand the procedure, you have to get the consent from the parents or the guardians. And for emergency procedures, if the patient is unconscious, you as the caring doctor can sign on the patient's tickets and go ahead with surgery. And later obtain consent from the patient's next of kin. Well, this is a picture of a multi-monitor which you might use sometimes before surgery, not generally, especially if the patient is after a trauma, and you might set up monitoring. Now in this monitor you can see the patient's ECG trace is here. This is the respiratory. This looks like a CBP, and this is the respiratory rate, and this is the blood pressure, systolic blood pressure, diastolic blood pressure. This is the heart rate, this is the oxygen saturation, this is the respiratory rate, and this is the temperature. So not that you need to set up a multi-monitor all the time, set it up when necessary. Right, this is a picture of a pulse oximeter where you have a big monitor like that and a finger probe which shows the pulse oximetry reading. So how much of oxygen is there in the patient? So, and it what is seen here is 89% is the oxygen saturation, and 87 is the pulse rate, which is taken from the pleth record that is being recorded by the machine. And so this is another pulse oximeter which has a which has the monitor on the finger probe. So now let's look at analgesia or pain relief. So sometimes there will be patients who are in severe pain or mild or moderate pain before surgery, and you have to control pain before surgery. Don't wait for the anesthetist to see them and then control pain. So when it comes to pain management, it's very important that you as a doctor get on top of pain first and control pain. So WHO pain ladder is something that you will learn when it comes to learning about pain. There's another set of lectures under pain management. So this WHO pain ladder, you can either climb up the ladder or go down. So climbing up the WHO pain ladder is not relevant for acute severe pain. So you have to start treatment from the top of the ladder. Start from the top and go down. That is what is recommended for acute severe pain. So pain management has to be multimodal and multidisciplinary. We'll discuss those things later. And let's say if your patient is in severe pain, for an example, if the patient is after a trauma, or say he has a fracture or dislocation, say dislocation of the temporomandibular joint, or fracture maxilla, or fracture mandible, or if the patient has an abscess like an oral abscess, or if the patient has a septic tooth or a chronic badly infected wound, then the patient may be in severe pain and you need to control pain. So if the patient is in severe pain, you can give a subcutaneous morphine dose, let's say 0.15 milligrams per kilogram. Then give diclofenac sodium as an oral tablet or rectal suppository, and start the patient on paracetamol, or you can give 2 tablets of rapidine, which is a combination of paracetamol and codeine. And Panadine is another trade name of combined tablets for paracetamol and codeine. Right. Next, it's important to keep patients who are waiting for surgery warm. Keep them warm. So don't let them be subjected to hypothermia. So keep the patients well covered with clothes and sheets or blankets or whatever. Especially children, elderly, and weak patients are more prone to hypothermia. And hypothermia can later lead to hypotension, low blood pressure, arrhythmias, poor coagulation, and they can have extra bleeding in the during the surgery and in the postoperative setting, and they will have poor neuromuscular recovery from at the end of the surgery. You also need to concentrate on fluid balance on patients who are waiting for surgery. Generally, it's not a big issue except for patients who are after trauma or who are after major fluid imbalances even before surgery. Generally, it's not a big problem. However, you have a separate lecture on fluid balance, so greater details can be discussed in that lecture. Anyway, in summary, you should see whether there are previous deficits of fluids in this patient and whether they have to be corrected. For example, if the patient has vomited, or if the patient has had diarrhea, loose stools, or if the patient has had excessive sweating, then you need to give maintenance fluids for patients who need maintenance fluids, not an ordinary patient. An ordinary patient can fast for 6 hours or 6 to 7, 8 hours even without a problem, and see whether there are ongoing losses which have to be replaced. This is particularly applicable to patients who are after trauma, whether they have bleeding or other fluid losses. Acid base and electrolyte balance is generally not a problem in most of the patients. It will be of relevance for patients who are very sick and patients who are after trauma, or patients who are coming for repeated surgeries, or patients who have a severe infection or major electrolyte imbalance. Yes, in those patients it's important, but you have a separate set of lectures on these electrolyte and acid base balances. We can concentrate on these subtopics in those lectures. So for the moment, we don't have to discuss anything about those things. But remember, these are concerns in a certain set of patients. Well, nausea and vomiting is again something that you have to be concerned with. So a patient having nausea and vomiting could be due to many reasons. So it may be due to medicines like opioids or non-steroidal anti-inflammatory drugs, even paracetamol, tramadol, and nitrous oxide can cause these things. And patient may see whether the patient has a history of gastritis or reflux, whether the patient has a past history of post-operative nausea and vomiting. So this time also patient might have post-operative nausea and vomiting. And non-smokers tend to have uh, post-operative nausea and vomiting more than even smokers. Eye surgeries and ear surgeries, sometimes even sinus surgeries are associated with vomiting. And if a patient is vomiting before surgery or nauseated, you can use an intravenous antiemetic like ondansetron 4 to 8 milligrams, metoclopramide 10 milligrams, or promethazine 12.5 to 25 milligrams. And you can use either rectal or intravenous mode, because once a patient is vomiting, it will be difficult to use oral drugs. The patient will vomit even the oral drugs. So rectal suppositories like rectal domperidone 5 to 30 or 60 milligrams rectal suppositories can be used. Now the last slide on preoperative assessment is going to be the first slide in another lecture that you are going to see after some time. That lecture is on trauma care. So if your patient who is waiting for surgery is a trauma victim, and there are certain principles of management, so you have to prepare the patient and go through the patient in a methodical way. Like, so immediate care is what is important here, and you have to do a primary survey and a resuscitation, like here, and do a secondary survey and plan for definitive care. So your surgery will be part of the definitive care, or your surgery will be part of resuscitation. So we can discuss those things later. So that's the end of this lecture, and we talked about preoperative care with special emphasis on preoperative assessment, and we learned that we have to do a preoperative history taking, relevant examination, and perform relevant investigations, and continue most of the medications that the patient was on all this time, and discontinue certain drugs, keep the patient fasting, and attend to analgesia, fluid balance, electrolyte balance, and acid base balance in special circumstances. Thank you very much.